So a lot of it begins with your visit to the Driver's License Bureau, and they ask you that question, do you want to be an organ donor?
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today, our topic is life-saving. Since 2013, President and CEO Patti Niles has spearheaded the life-saving mission of Southwest Transplant Alliance, growing the organization into a leader in the organ recovery industry. Please join me in welcoming Patti Niles to the Business of Healthcare podcast.
Thank you, Bob. It's a pleasure to be here.
Well, Patti, if I'm typical, then I don't think I'm alone. Most people do not fully or even partially understand organ donation. How in the world did you get into this business? What is your story?
Boy, it's an interesting story. I understand that you don't understand the business of organ donation. And I was an intensive care nurse for 10 years and really didn't know that I didn't understand it as well until I got into the other side of it. It was an interesting start with this career. I was a bedside nurse, took care of intensive care patients and sometimes people who got the transplants. I love that side of it and watching them recover so quickly and become vital working people again after their transplant. So I wanted to be a piece of that. So I decided to throw my resume into the hat and apply for a job in the transplant center. So I was called for my interview and I was sitting through the interview and they were talking about organ donors and how they get them and authorize them. And I was just scratching my head going, but this isn't the job I applied for. Well, it turned out my resume got thrown in the wrong box. So I was interviewing for a job that I had not just interest in, but I didn't even know it existed. So it kind of opened Pandora's box and I wanted to find out and hear more. So I kind of job shadowed them for a little bit and then I took the job and 30 years later, love my job still to this day. So I kind of grew into this job. It's unusual to be a nurse and then kind of follow that path into CEO of such a large organization. So it's been an interesting journey, and I'm so glad that I've landed in Dallas with this organization that really is one of the leaders in the country.
So burnout, is that something you experienced in the nursing area?
It was. I always say you have so much sympathy in your bucket, and there at any given time, depending on how much goes into that bucket, you fill it up. And mine was full. And I realized that I wanted to be effective and I wanted to continue being a caring person. And it was a hard job. And I got a little, not cold, but I got a little unsympathetic to my patients. And I decided that's when I needed to change. So I remember the patient. He just had open heart surgery and had his chest cracked, right? So he obviously is in pain. And he was being a little whiny. And I remember rolling my eyes going, okay, I need to change because I lost my sympathy for him.
So you went from one side of the equation to the other side then?
Completely different change. Yeah.
That's interesting. On a previous podcast, we had the founder of an organization called RIP Medical Debt, Rest in Peace Medical Debt, Craig Antico. And he was a medical bill collector for 30 years. And he had a similar story in that I want to get on the other side of this operation. I want to make a difference. I want to restore hope. I want to basically have such an empathetic perspective on making a change in people's lives. And that's where you ended up. It sounds like a complicated business. So how in the world did you go from, being a nurse into being the head of an organ donation company? I mean, that's quite a set of skills that you have to acquire. How did you come about that change?
Well, I'd have to say I'm one of those leaders. I lead with common sense, and it has gotten me very far in my journey. I was a coordinator for about 10 years with the program that I worked with in Ohio. I took my first leadership job. I went across the country to actually Las Vegas, took over the program in New Mexico, and then here in 2013 in Dallas. I learned a lot along the way. I was kind of some people are born leaders. I think probably I had some of that in me, but I also was given the opportunity to grow in all those different positions in all the years. So I lead with common sense, and I also lead with that I'm a nurse first. So if you sit next to me on a plane and you ask me what I do, I'm probably going to tell you I'm a nurse rather than I'm a CEO. That's just kind of the first answer out of my mouth.
Well, that comes from your heart, I'm sure. So I can only imagine, I really don't know enough about the whole process, but I can only imagine it may not be just complicated. It might be complex. Complicated things usually figure out, but complex things are so many variables that quite often, no matter how good your procedure is, the outcome doesn't make it. The outcome fails. So share with our audience here just what's involved. A ton of process. How complicated or complex is what you do? Give us an inside picture. Take us on a journey, if you would.
So a lot of it begins with your visit to the Driver's License Bureau, and they ask you that question, do you want to be an organ donor? So a lot of it starts there. So we have to develop that relationship with the DMV so that they know that that's the necessary ask. So there's a lot of community education so that when you go there, you'll be a little prepared and want to say yes. So we do a lot of community education. And then we also do, in parallel, a lot of work with our hospitals. We have in our service here, we have over 250 hospitals that we have to be in daily to remind them, the nurses and the physicians, to know when to call us. If they don't make that call at the right time, or if they don't make it at all, that's a potential of 8 lives that are lost because that one call was not made. So that's significant. So we're always looking at ways to make sure that we're kind of at that forefront with the hospitals and they know when to call. You know, it's at the end of life when the physician and family has decided there's nothing else that can be done as when that call needs to be made. So we have that work to be done. And then we have the group that goes in to talk to families about when that option is available. So when a family is having to make those decisions, we have a very special group of folks. They're the ones that you want with you at such a tragic time. So they sit with the families. They're like chaplains, social workers and such. They sit with the families and walk them through the different options. And then if the family agrees or maybe that person has already agreed on their driver's license, then we have a clinical team that come in. We also have the intensive care nurses who come in to manage and try to find homes in matches with those organs. And then, of course, at the end, when it's surgery time, we have the group of physicians, surgeons who come in to do the recoveries. So that process I just walked you through is about a 2 to 3 day process that is all about timeliness. Everything has to happen at the right time. So when we have a storm come through and we can't get airplanes in, that delays. And sometimes we actually lose organs because of weather. So we're always looking at ways to do things better and different and more efficient.
So Patti, you really need to find a way to make things happen. Now you mentioned the hospitals. They provide you, they're the key starting point as far as the process of dealing with these important matters. Doctors and nurses, isn't that something that's mandatory for them? I mean, they would never turn their back on something like that, would they? Is there a process in place to ensure that when these conditions occur, that they will be acting responsibly and reaching out to you, or does that sometimes have a flaw as well?
So Medicare does mandate that the hospitals call us. So that is in place. But the practical side of it is that they're busy, right? They are busy with so many patients. So sometimes they call too late, and it's not deliberate. It's just that human factor of they have to know when to call. So we're trying to work with some artificial intelligence and working with some of the medical records so that it will almost alert them to know when to do it. So we're trying to put fail-safe systems in because, they are busy folks and sometimes it does happen.
Are there restrictions and exceptions to qualifying? Like, for example, if you have, just say, for example, if you have HIV or if you have hepatitis, are those like you check them off the list, or do the doctors and nurses have to know a lot about that patient to say they're good to go or they're not?
We ask them to not rule anyone out because what is an exception today probably won't be an exception tomorrow. The big exception is like the big cancers, the metastatic cancers. Those are the big rule outs. But everything else, like you mentioned, hepatitis, we've come a long way with treatment. Sometimes we'll match up those recipients and the donors who both have the hepatitis. HIV, 5 years ago, that would have never happened. Now we can actually match up HIV donors and HIV recipients. That's been in research in the last few years. So we've made that happen. We have recovered organs on HIV donors. So I would say never think about ruling yourself out. A lot of people will go, oh, I have diabetes or I have high blood pressure. Most likely you can still donate something.
Yeah. So we're in a real tragic pandemic right now, and a lot of people are dying COVID-19 related. Is that a barrier, or would those people qualify for organ donation as well?
So today we do roll active COVID out. If you have had it and you've tested negative, we will consider that. I do think that's probably going to change in the upcoming months. We know for lungs, we would never transplant COVID lungs because that's where the disease actually lives. So we know that's not an issue. People who have severe COVID are actually getting lung transplants. That's kind of new. I think we've only had 2 or 3 in the country. So that's actually something that's coming forward. But I do anticipate it won't be a rule out forever because we're learning so much about COVID.
You had mentioned earlier, Patti, that CMS, Medicare, they're required to work with the hospitals. And you also mentioned that they define the territory that you have. Mm-hmm. So in your particular organization, what part of the geography do you cover?
So I cover from El Paso to Texarkana and then pockets in between. It makes no sense. If you saw us on a map, you would go, this makes no sense. I wish Medicare would fix it, but they don't seem to be able to do that. I don't have Fort Worth, but I have like Galveston and Beaumont just below Houston. Yeah. So Houston doesn't have them, but it's a mess, unfortunately. It makes it difficult.
So the hospitals, they have JCO, the Joint Commission, that basically, requires them to have certain standards, and the hospitals are participating in that. Is there any agency like JCO that looks into, the way that you do things and your processes and your reporting and things of that nature?
So we are Medicare regulated. So they do come in and audit us. We have metrics we have to meet with Medicare. So we have audits by them. We also have audits by the United Network for Organ Sharing. They're out of Richmond, Virginia. They hold the contract with the government for the organ procurement organizations around the country. We also do tissue recovery that is regulated by the FDA. So the FDA also comes in. So we have lots of surveyors and auditors who come in to regulate us.
Oh, that's terrific. On one hand, it's terrific. And on the other hand, it's good news and it's bad news as well. Yeah. So I know you talked about relying on hospitals, doctors, and nurses, but what other kind of partners do you depend on?
So there's a lot of partners that we work with. Certainly healthcare, that is our biggest niche. And we also have a large volunteer base. We have a foundation. We have a foundation that helps us with research. So we have a lot of research partners that we work with. We've contracted with Johns Hopkins to do research. We have a partnership with UT Dallas with some of the researchers. We help with UT Southwestern with some of their research. So we have kind of paths in a lot of different communities, but most of it is research and related to healthcare.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
A lot of people we were talking about efficiencies and changes in process and improvements, whether it's an agile management methodology or some type of understanding of how things work. So let's just suppose you've got a donor in Arkansas, and how do you respond to that? What kind of resources do you need in order to take care of that, and how timely that all has to work? Kind of fill in the gaps for me on that.
Sure. Well, I don't have Arkansas. I do have Texarkana, which is on that border. That's really darn close. So currently, the way that is, and this is how most organ procurement organizations operate. When we have a referral, we go on site. So let's say that's Texarkana, which is 180 miles one way. So I send a member up, and we get a yes from the family. So now that case is going to last a couple days. So in the course of those next 2 days, I'm sending about 8 teams. So there's a lot of going up, driving back, going up, driving back, to the tune of about 2,800 miles for that one particular case. So after we're done and we found the recipients, now I have to fly the surgeons up. So that's 3 chartered airplanes. So on top of 2,800 miles of driving, now I have 3 chartered airplanes. You can just imagine the inefficiency in there and the cost. That's really costly to do all of that travel, and unsafe conditions sometimes in bad weather and such. And just being on the road that much I think is risky. So we have a new system that's we're going to move the donors to Dallas, to our recovery center, which makes sense. So rather than having all those trips out, we'll bring one donor in. So it reduces the time that the surgeons, who have busy lives, and sometimes our operating rooms have to work around the schedule at that particular hospital. So they might bump us to like 10 p.m. when there's no other surgery scheduled. So now our surgeons fly in for a 10 o'clock surgery. They're going to be up all night. They bring back that organ to do the transplant. So they've gotten no sleep. So again, an inefficient system. So our medical community is extremely excited about this because it makes a lot of sense. We'll still be able to take care of the families. If the families decide they want to come, we have a special place for the families. So we've thought about all of those things. This will be the first of its kind in this part of the country.
Wow, you said it makes a lot of sense. I'm going to go back to what you talked about earlier. It makes a lot of common sense. Yeah, Congratulations. Congratulations on that.
Thank you.
I can only imagine the quality of life. I mean, physicians and everybody else in this healthcare world, they get burnt out.
Yeah.
And if you were a medical doctor and you have to, after a long day of working here, get on a jet and, work throughout the night and continue on when you get back, that would just add to the burnout factor there. So that's a really, really innovative perspective on that. It must tie back to, I think you've got a relationship with UT Dallas, don't you?
I do.
Tell us about that. I'm kind of curious.
I had the opportunity, I think it was a couple of years ago, to get the executive certificate in nonprofit governance. I was excited to find out about that group, and it's been useful both as a CEO with my own operating board. I have a board of governance, but it gave me some insight into really what's required, that when you talk about fiduciary responsibility, what does that mean? So that really helped me help my board. And then on the other side, I'm on a couple other boards. One of them is Prism Healthcare North Texas, which is an incredible organization. They handle the care of HIV and AIDS prevention and treatment, really great organization. So as a board member for them, I now have better skills. So it's well-rounded me and given me some skills and knowledge that I really didn't have before.
Well, it's lifelong learning. And, most of what we teach in the university, we've got some excellent professors and staff, but a lot of the learning comes from the networking of our executive education students. They share different ideas, different processes. They generate and innovate like you have, new ways of doing things. So that's really nice. About your board and fundraising, how do you go about raising money?
We have a great mission, and it's easy to kind of wrap your arms around our mission. So we have much like anyone else who has a foundation, we are out there seeking. A lot of it had to do with our new construction that we did. We built a new facility, so we had a lot of campaign requests for that. We have this beautiful donor memorial garden area that the whole building is centered around. We have this beautiful sculpture that representing the donors and the recipients. So those were easy things to kind of wrap their arms around. But we also have this big research arm. We're one of the few OPOs that does a lot of research. We work with a lot of partners. We're trying to do better, not just ourselves, but donation and transplantation as a whole. So that's one of the arms of the research and the foundation. The other is giving back and trying to help the people who get transplants. There are some recipients who struggle. You can just imagine now with any kind of job layoff or even after a transplant where you can't go back to work and you need this medication and you can't pay for it. So we have the foundation that kind of helps with those requests. So we do help with some of the recipients. And then on the donor support family side, those who have just tragically lost a loved one, we offer support to them. So those three things, the donor care, the recipient care, and the research, our foundation kind of funds.
You mentioned the name OPO. That's the organ, what was that?
Organ Procurement Organization.
Organ Procurement.
Yes, OPO.
That makes sense.
Yes.
That's what you're doing. You're actually procuring these organs. So OPO, I don't want to confuse it with opioids or opiates or any other thing. So that process of working together, do all the OPOs, do you guys have OPO get-togethers where people like yourself share best practices? Is there any type of system organization that you guys focus on and look at problems together with?
There are 58 of us throughout the country. We're non-competitive, so Medicare kind of defined our border. So because we're not competitive, we share, and we do share a lot of best practices. So there's a national association that kind of helps us do that.
Well, I know that the airline industry is the same way. They all compete, but when it comes to quality and safety and things like that, they truly unite, especially when there's a tragedy of sorts. They all work together. When I think about that driver's license situation, to me, I go, yeah, I think I did that on the back of my driver's license, but I just lost my driver's license the other day. Do I need to have it on me? Or how do they go about connecting that point? And how do you go about communicating to the public that it does work? It's not some gimmick type thing. Because quite often you think of organ donation and you think of these urban legends where somebody's in Vegas and, they're in an ice tub in their hotel room and their kidney's missing or something like that. So how do you build confidence with the public to understand that process works? And if you move, do you have to get a new driver's license and sign it as well? What are some of the details on that? Because I think that's a critical step.
Sure. So I'll talk about kind of the process first. So when you're at the DMV and they ask you, do you want to be an organ donor? You check a box and you sign it. That is your now legal consent to be an organ donor. So the information is in a registry that the DMV has given us access to. So after someone's death, when we get the referral, we do access that. So let me talk about the humanistic side of it. And I'll talk from my experience as a nurse who's worked emergency rooms and critical care. When somebody comes in, your healthcare team trying to save your life is interested only in saving your life. And by nature, we care about those in front of us, right? When we're in front of us, this is the only thing that matters. They don't care if you're an organ donor or not. They don't get that driver's license. If it's an accident, the police department takes your driver's license. So healthcare folks in the hospital don't see your driver's license. And quite frankly, they don't care. They're focused on saving your life. So they're very separate from my organization, and we keep it very separate intentionally. We want you to have the comfort and knowledge that the people at the hospital are trying to save your life. When that fails, when your life is gone, they call us and we come in and look for that information. So it's a very separate line. And just as the humanistic part, you're only interested in that person in front of you, not those 100,000 people on a list somewhere that you have no idea who they are. So that's just putting that myth aside. A lot of people have that fear of, if I sign up, they're only going to be interested in my organs. And that is so not true, because it's a very separate process.
Once again, that's a big education component, I'm sure, is to have people really understand the value of all this. So a couple more questions here before we wrap up. What is the number one organ that gets donated?
So the number one is kidneys, because we have 2 of them. So there are more people also waiting for a kidney transplant than any other organ, because they have backup systems, meaning dialysis, right? So if your kidneys are failing, you end up on dialysis. So you have a poor quality of life because of it. You're really tied to that dialysis, sometimes 3 times a week. It could be 6 hours a day. It's exhausting. So more people are on the list, and then more people can donate kidneys. And of course, there's livers, hearts, lungs, small intestine, pancreas as well. So many other options. Of course, tissue as well. Skin can really help those burn victims, and bone can help those with all kinds of bone fractures and such.
Last 2 questions here. The youngest donor and the oldest donor. What do you think? What's the range on that?
Wow. So the youngest was probably days old. So, there's babies waiting for organs. So we would recover, on a brain dead infant. And then the oldest that I've seen is 85, 86. So you can't rule yourself out because of age. I always say there's some really old 30-year-olds and there's some really young 80-year-olds.
I'm a real young 66-year-old, so...
There you go.
So, Patti, this has been a great pleasure talking to you about what you're doing and how you're doing it. I think it's been very, very educational. And if there's any message that you want to get out to the public, here's your opportunity to give it. And also, we'll put a link on the podcast posting as well with any reference position that you have. So I'll give you the final word.
All right. So if you have not signed up to be an organ donor, you can do that today simply by going to donatelifetexas.org.
donatelifetexas.org.
Yes.
Very good.
I'll get you there.
Well, thank you again, Patti. We've enjoyed this time with you, and I think this is a great public service that you're advocating, and your passion and commitment is an inspiration to everybody. So thank you for what you're doing.
Thank you, Bob. I really appreciate this opportunity.
Okay.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.